Hello, bonjour. Bonjour. Merci par l'invitation aujourd'hui. My Uber driver from the airport said you should try to speak some French today. So I said, okay. I'm going to just take you through some of the colorectal, and I apologize for some overlap with Dr. Gagnier's presentation. It's a really interesting history, and I kind of got into the history a little bit because it tells a little bit about the engineering and where we'll go. And I don't have any relevant disclosures. I authored one of these manuscripts, but that was a long time ago. So this is the original compression anastomosis proposed by Denon. You can see it has a wrench I was able to find a picture of that is utilized during its application, an internal conduit, and this was first described in 1826 and then published a year later. And what's interesting is they were already talking about some of the things we're talking about. So the introduction of a magnet or a compressive device does narrow the lumen a little bit. So we worry about narrowing the lumen. How will it heal? What kind of necrosis really hadn't come up much yet. And then came the Murphy button. There were some iterations, but J.B. Murphy was a physician at my alma mater at Cook County Hospital. He was the president of the medical staff, and produced this publication that really involves all types of anastomoses. So gallbladder to intestine, stomach to intestine, intestine to intestine. And this button could be utilized for all of them. And this button used two brass springs to exert the force. And you can see them in the cutaway shot on the original manuscript. And what's interesting about springs is that when it springs in its natural state, it doesn't exert any force. And then as you compress it, which you would have to do to apply it, right, it exerts more and more force. And then as it comes back, as the tissue necroses and heals, it's less. So the force, and that's Hooke's law or equation. And so the idea is the maximum of force is at day 0. And then as the anastomosis forms, it becomes less and less. And that's a little bit different than magnets. Magnets, when we begin, are further apart, and they exert less force. So one of the magnetic devices exerts about 3 newtons when you initially insert it. And then as the two magnets come together and they get closer and closer until they're opposed, it's about 12 newtons of force. So these are different things. And then I'm also going to talk to you about how things might just be snapped together in the OR, the BAR anastomosis. And so when you snap it, there is the most force usually presumably on day 1, because the tissue is the thickest, right? And then as it necroses and becomes thinner, there's less force. So as you look through all these papers, I began to think, well, what's the difference? Unfortunately, it's really hard to show. Like all studies in anastomotic leak or anastomotic bleeding, it's just these are small numbers, and they get challenging. But something to remember as you look at all of these. And the goal, of course, was it's the same 130 years ago, was tissue approximation without stricture or retraction. It says contraction, I think not retraction. And Murphy says this in the paper: "How much I have accomplished by my labor, I desire you to be the judges." So you'll be the judges today. The magnets come onto the scene in 1980. There were 5 patients at least in colorectal surgery. There were 5 patients undergoing sigmoid resection and low anterior resection, and they used a rare earth cobalt bonded to a polymer. And this is when the authors, and I kind of wrote this specifically, note optimal circular apposition of the submucosal layer. This is sort of the first time you see the submucosal layer, or at least the first time I saw where they start talking about that, which is where a lot of important strength and healing occurs. And they describe the necrosis. Progressive compression leads to necrosis of the intermediate mucosa and submucosa by increasing the magnetic force while intestinal healing takes place. Next up comes this device. It was originally developed in the Soviet Union. It's the AKA-2. There was eventually an AKA-4. And this is non-resorbable. So you're going to see resorbable and non-resorbable devices. And this also allowed a transanal application. So like an EEA stapler that we're all familiar with. Metal pins with rings are attached. You can actually make out the springs there. On the top right, you can see little springs around the pins. The springs generate the force that pushes the pins inverted in resection into the white ring. And so that's another device. And the first time we see it in an EEA form. And then there was the BAR, the BAR in 1985. This is a biofragmentable anastomotic ring. So it's made out of, as mentioned earlier, Dexon and barium sulfate. So it begins to dissolve and fragment and pass in the stool a week or more later. One, in the design of this, and the design is kind of interesting, this is when you see scalloped edges. You see how it has those? These are, by the way, equal parts. They are identical, and they snap together. And the authors theorized, I'll show you in the next picture, that scalloped edges avoid necrosis at the site of bowel approximation. They came in multiple sizes, diameters, and 3 gap sizes, depending on if you were doing a gastrojejunal or in a small bowel. And then here's what that looked like. And so that's why they were saying their scalloped edges avoid necrosis at where you want the submucosa to come back together. And then snapping rings. These were the snapping rings. This is a 3-part system. And the authors, and this was actually in Annals, it was a very comprehensive surgery or publication that showed the histology, the ex vivo and anatomical pictures. You can see that that's an anastomosis and you can barely see it. One of the things where it's healed, and one of the things proponents of the compression anastomosis note is there seems to be less inflammation at the site of the healing. And definitely in all the histology and anatomic pictures that I saw in these reviews, that appeared to be the case, just like this. That's a beautiful anastomosis. They also showed extremely high bursting pressures. You need a bursting pressure somewhere over 70 with an anastomosis. You can see day 0, you've got a 350 to 500 bursting pressure, very high. And then, and this is really, just disclosure, the one I've used and published on, was the endocar, and then the CAR 27. These are nitinol, so this is in the gold leaflet springs you can kind of see on the top picture to the right. And what's interesting about these nickel titanium alloy springs is that they exert equal compression independent of tissue thickness. So that's a really different approach. At least they felt like it was. And then you can see it here in the bottom right, inserted into the bowel. You can see it's kind of bulky. And that was always something that bothered me a little bit about it. I felt like the intestine was sort of stretched over it. And there's actually a stapled anastomosis a little lower down, and you can see the staples there next to that physician's left hand. And so this is just before we go into clinical outcomes, I just wanted to summarize some of the early research. So over and over, the papers talk about equivalent burst pressures. They also talk about no hypertrophic scarring noted. So there was some concerns about that. No issues with obstruction. Luminal narrowing was not a problem, even though these devices do take up some of the lumen. And there are a lot of pictures that show decreased tissue inflammation. However, there was one study out of WashU that was with the NITI endocar that actually looked at tissue inflammation, looking at markers like MMP2, 9, and the difference in collagen and elastin deposition. And they compared to a stapled anastomosis. And they were unable to show any difference between the NITI nitinol anastomosis and standard stapling, but they did say we just spot checked it at 14 days. There may have been much less inflammation earlier. It may have just been over by 2 weeks. So, but that's just one thing to note. And so now we'll delve into clinical outcomes. And so I just tried to keep it to the biggest studies because there's a lot on this. These all start with small animal studies, then small groups of cohorts of patients that are relatively healthy, and then get into more pragmatic large clinical trials. And the AKA2, this was one of their largest, 442 consecutive patients. Bleeding is very low, stenosis is very low. And what was nice, and I included the table here, you can see they included level of the anastomosis. In colorectal surgery, we believe that the lower the anastomosis, the higher the leak rate, so we try not to mix different heights of anastomosis in our leak rate studies. And so you can see that the highest risk, which would be the under 5 centimeter anastomosis, in all patients, there were 3 leaks, or I'm sorry, one leak out of 35 patients, that's 3%. And then you can see patients without a diverting stoma, they were using diverting colostomy for their low anterior resections. You can see a leak rate of 5%. There are many studies that show leak rates at low LAR as high as 20%. So this is really interesting stuff. And the overall leak rate, you can see 2.5 to 2.7%. It's very low in the anastomotic world. The BAR. This was a study published here at McGill, and the BAR. Just to remind you, it's the dissolvable one. Okay, that's held. Each side has a purse string, and I thought this was an interesting summary of all of the data. So they did their current series, and they used it robustly. Very pragmatic clinical trial approach, right? And you can see that they used it in 13.9% emergency surgeries, which is a lot. That's how a surgeon might use it in real life. And the leak rate even there was 3.6%, including a fairly high rate of emergency surgery, which gets left out of most anastomotic trials. You can see, and they're at the bottom, the current series, 0% obstruction, 0% stricture. And then you look at the totals. So this was tested in many people, 1,523, where we have the data recorded, and the leak rate was 3%. It's low. And some things the authors note. Technically, this had a really steep learning curve, and they said initially, you had to figure it out. There were 3 gaps between that you could select from, and choosing a gap that was too small was really problematic during surgery. And they note that, and once they figured it out, they felt pretty good about it. I should also note those fragments pass at 8 to 10, 11 days. Now the NITI, this was one of the studies we did with it, getting on to be 10 years ago. And this was a registry study. It was very large, a lot of data from 16 countries to look at the performance of the NITI car. And we included laparoscopic and open, and you can see there was a lot of surgery going on with this. And this was just over a couple of years. The overall leak rate was very respectable at 3.22%. Median length of stay was 6 days. Expulsion time was 8 days. The earliest expelled at 6 and didn't leak, which is kind of interesting, and just a kind of a note I always thought about. There were only 4 technical failures. The NITI, it sounds pretty straightforward. It could be a little complex. You had to chill it, the nitinol before you inserted it, just in a cold water ice bath. But and then inserting it, it was always a little tight over the device, and I never knew what I would do with an air leak if I saw it, because it'd be really hard to put a reinforcing suture over the serosive that was pulled so tight. Here is another sort of summary of data, systematic review. Anastomotic leak rate with the NITI was 2.2%, and with stapler was 3. Sorry, I had the stapler number wrong there. It's 10 out of 325, sorry. And those differences were not statistically significant, and I wanted to include the forest plot for you so you can just get the visual of the differences. You can kind of see one study, Dowser 2013, was sort of favoring the car, and you can kind of see the Koo study in 11 was favoring staple, but really there was no difference at all in this systematic review. And then what's in the future? I think they've already spoken about it. We've heard about the self-forming magnet. That's really interesting. It's a gold polymer mix. And then you have actually this was out of a biomedical engineering journal, an active electromagnetic system. Again, with an active system, you can vary the force. I don't know where the wires will go, but it's quite a device, and it's on the horizon. I think that's an area that people are going to look a lot into in the future, and that's all I have. Thank you very much.
Thank you so much. The final talk I'll be presenting on magnetic and compression anastomosis in pediatric surgery. And I really love being in an adult session so that I can hear all the cool things that the adult surgeons are doing. So for my financial disclosures, I am a consultant for Hologic, which is not relevant for this. What is more relevant is that I am a consultant for Cook Medical, and I am the PI for the Flourish study, a magnetic device that I will be discussing in this presentation. So in the peds world, magnets have been used for a variety of anastomoses since about the 1970s. And this is a series that was published by Dr. Hendren and Hale in 1975 on a series of 4 patients with esophageal atresia. So they use these electric bougies that you can, oops, sorry about that. Can you go back one slide? Thank you so much. You can see those metal bougies that they used in the patients with esophageal atresia, and then use that magnetic, pretty torturous looking device there to put the babies in. But they were able to achieve lengthening of the esophageal ends with the ability to do a subsequent repair on all 4 of the patients. So I'm going to talk mostly about esophageal atresia and the use of magnets, although I'll touch upon a couple of other applications at the end of this presentation. But just to remind the adult surgeons in the room here, for esophageal atresia, this is the typical anatomic classification that we use. And we'll really just be focusing on the type A esophageal atresia patients. This is in about 8% of patients, which is we call pure esophageal atresia, where there's no fistula. And the type C, which is the most common type of esophageal atresia with a distal tracheoesophageal fistula. So patients that have a long gap esophageal atresia are a really technically challenging group for pediatric surgeons. I sort of define this as any type of esophageal atresia where the 2 ends of the esophagus don't come together without tension. And that can really be developed or formed for a lot of different reasons, but we have a lot of different techniques that we can use, which I won't go into, but you can see them listed. And of course, whenever there's a list of different techniques, that means that there is not one optimal technique. But in general, these typically require multiple operations, repeated anesthetics, prolonged operative time, and overall just significant physiologic stress to these babies. So the magnetic device called the Flourish was developed as a non-surgical alternative for esophageal anastomosis. It does promote the lengthening and approximation of the proximal and distal ends of the esophagus, and it works by using compression anastomosis. I won't go into that in detail since it's been nicely discussed by our previous presenters. But as you can see, this is a catheter-based device, so they're placed within the 2 ends of the esophagus. They attract one another, and over time, come attached to one another and couple, and then the compression anastomosis is allowed to create the anastomosis. So this is just a little bit more about the Flourish device. There are some other magnets for esophageal atresia that are used clinically, but this is an FDA approved, still as a humanitarian device exemption that's created by Cook Medical, and it is what I'm most familiar with as well. So as I mentioned, there's an esophageal and a gastric catheter with an inner bullet-shaped magnet. It does taper down to a 10 French coupling surface, and that helps to allow for the gradient compression. The proximal portion does have a suction port, so that allows it to suction saliva. And the gastric port has a channel for feeds, so while this device is in place, the babies can still be fed. And this is how it's performed. I'll go over this fairly quickly, but it's a fluoroscopic guided procedure. We typically advise to do it in the operating room, but theoretically can be done in interventional suite as well. The first step is really critical to measure the gap. So we do gap studies prior to, making them a candidate for the operation. But it's very important to actually measure this gap on the table as well. It's very important that there is no pressure placed on the two ends while measuring this gap. And the gap does need to be less than 4 centimeters for the Flourish device to work. Otherwise, it exceeds the strength that the magnets will be able to sense one another. And then the gastric catheter is placed over a wire. That sometimes can be very easy, sometimes a little more challenging due to finding the G junction. So I always keep an endoscope with me so that can assist placing that portion. Next, the oral catheter is placed. We recommend to place that within the nares if possible, or if the nose is too small, sometimes that can go orally as well. And then once the magnetic devices are placed, a daily chest x-ray is obtained. This is one of our patients that you can see that the gap initially was about 3.2 centimeters. And then continue to do chest x-rays until the magnets come together. And then finally, you can see a successful anastomosis. That's usually noted by either saliva in the G-tube, feeds in the esophageal catheter, or an esophagram can be placed, as you can see on this demonstration here. And we've seen that to typically take about 3 to 13 days to form the anastomosis. I put here just a table of retrospective studies that were performed and published on the Flourish device. So as you can see here, most of them were primary anastomoses and kind of a variety of different number of patients. All were able to achieve a successful anastomosis, although the vast majority did have strictures that required at least dilations. A couple had esophageal stents placed. And our series that we published at the bottom of the table there, we had 13 patients, and we did have 2 patients that required surgery for a recalcitrant stricture. But all in the end were able to achieve full feeds. So we've currently just completed a prospective single-arm observational study looking specifically at the safety and benefits of the Flourish device. This is a Cook-sponsored study that is part of the post-FDA approval use study. And I won't go into details of it, but the eligibility for the study were patients with esophageal atresia that had an atretic gap less than 4 centimeters with either a repaired or an absent tracheoesophageal fistula. And importantly, a gastrostomy tract that can accommodate an 18 French catheter. We typically will place 12 French or 14 French G buttons initially, but the actual device requires an 18 French dilation just prior to the placement because of the size of the catheter. And then for the outcomes, we're looking at stricture, anastomotic leak, or adverse events that's related specifically to the procedure or the device, as well as successful anastomosis. So the procedure was completed in 20 patients. Unfortunately, the last patient's data still needs to be accrued, so the data will fully be analyzed in November of 2023. So hopefully I'll be invited to come back next year and present that data. We are now in the plans of establishing the next steps with the FDA. So sort of in summary for esophageal atresia, we found that the main complication, particularly in our retrospective studies, was stricture. Again, that magnetic coupling surface does taper down to a 10 French, so there's naturally going to be a bit of a taper in the anastomoses. But just to put this into context for our patients that we operatively repair, they tend to have a pretty high stricture rate as well. I do think that this can be particularly beneficial, like similarly to other presentations that were noted in patients that are very high risk for surgery. In the peds world, those usually include patients that have other congenital anomalies, particularly cardiac anomalies, previous operations, things of that nature. And what I didn't mention for time purposes, but it can also be used in combination with surgery. That was not really the outcomes that we were looking for in the study, but we've also had a number of patients that we've used it for postoperative strictures, non-amenable to dilation, and I think more importantly, as a staged fashion for esophageal gaps less than 4 centimeters, or greater than 4 centimeters, excuse me. And The other exciting topic that I'd like to just mention is that for surgeons trying to do more thoracoscopic procedures, this might help increase the utility because the thoracoscopic mobilization can be performed, and then the anastomosis with the magnet. As you can imagine, a lot of these babies are 2-3 kilograms, so the working space in the thorax, especially with the ribs, can make that anastomosis technically pretty challenging. So hopefully this could increase the availability of thoracoscopic procedures for the babies. And then currently there are some improvements to the device that are hopefully going to be coming in the future. So I'll just touch again about some other applications of magnets for other pediatric conditions. So for your pectus excavatum, that is a congenital anterior chest wall deformity, and it causes a depression of the sternum. You can see here on a CT scan what it looks like on imaging. And typically, surgically, we perform what's called a NUS procedure, in which we do a thoracoscopic assisted procedure and place a bar underneath the sternum, leave that for about 3 years where it remodels the sternum to correct that deformity. Dr. Harrison's group created a magnetic function to try to treat this condition. So a magnet is placed behind the sternum through a small subxiphoid incision. And then the patients wear an external brace, as you can see on the top picture. And that's just some x-rays looking at the postoperative pictures. So they've had some very good results with this technique. There's a multi-institutional study looking at their results, and this seems like a promising other type of technique. The next thing that I'll just mention quickly is for patients with congenital scoliosis. As you can see here on this x-ray, patients with particularly early congenital scoliosis, they have this very significant spinal curvature, and typically bracing does not work for many of these patients, so they need to be surgically corrected. This is typically a pediatric orthopedic procedure, which I do not do, but from reading the reports, the typical procedures include placing this rod, but typically they have screws with pieces of the rod that need to be re-implanted every couple or 6 months. So this was a device using a magnet with just one controlled growing rod that fixes to the spine, so it minimizes the invasive procedures that these children need. And then finally, there are commercially available magnets for the use in anal atresia, sort of a very similar concept to the esophageal atresia patients. And it allows for rectal lengthening as well as a compression anoplasty. So thank you very much for allowing me to speak on pediatric magnets. And then I will open it up for questions for any of the present panelists here.